right on to our next speaker, which is Dr. Dale Walker. Dr. Dale Walker is a professor of psychiatry and public health and preventative medicine. He's director of the Center of American Indian Education and Research at Oregon Health and Science University. He's the past president of the Association of American Indian Physicians, and he was twice winner of Physician of the Year from that organization. He's a nationally recognized leader and researcher on the topic of substance use disorder and addiction, and especially the roles that these conditions play in our Indigenous community. And he's a fierce advocate for healthcare access and equity for all patients that are suffering from mental health conditions and disorders. I asked Dr. Walker to talk to us today about a very important issue that has been on my mind, and I'm sure many of yours over this past year and maybe longer, about this topic of burnout, which, as we know, is three main characteristics: are the depersonalization, your loss of enthusiasm, and cynicism that you bring to work. However, I felt over this past year, especially when I was questioning, or actually even went from, you guys know me, you've worked with me, incredibly optimistic, enthusiastic, energetic, and when I show up to work, it's let's go, we can take care of this, no matter what hits our door. That's why we started in this profession. But I'd be finding myself driving to the res and actually scared that I wouldn't be able to take care of what was coming through the door. And it wasn't about depersonalization. Maybe it was a little bit about exhaustion, but it was something different that I didn't have a name for yet. And then I come to find that there's this, entirely different term that's moral injury that I knew nothing about. And that's why I wanted to ask Dr. Walker to come on to talk to us about it, because I think it's important to shed a light on it. I think it's important to discuss and support each other if we're dealing with these particular symptoms or feelings or thoughts. And I thank you so much for Dr. Walker for being with us today and sharing your valuable insight and experience.
Well, Ken, it's a great honor to be here. Let me try to make sure I can get started here and jump right into the. There we go. Am I on okay? Is the sound okay and the screen is up?
Looks good, sounds good.
Okay, thank you very much. What an inspirational meeting. Ken, just hearing the previous lectures, I've had the luxury of watching since the start of the meeting today, so I've been really turned on by the facts and the comments of the people that have been before me. I want to, before I start the talk, I want to mention something about the American Rescue Plan Act. I would encourage all emergency physician people across Indian country to start talking to tribal councils about what you need in the emergency room. Remember, there's $32 billion that's being made available over the next 3 years. And then we've got the CARES Act holdover money from last year. Now is the time to think about what are the things you need to do to continue to deal with the pandemic. And if we have the misfortune of a mutation or another pandemic of another type, are we going to be prepared? I think now is the time that you can take a look at that. The previous speakers were just wonderful to listen to, and I loved hearing the one comment from Dr. Klumpus at the end: stay humble. Less combined, stay humble to Ken's eternal optimism. Those are the things that keep me going through my entire career. I've worked for 45 years in American Indian country. I'm a member of the Cherokee tribe, and this has been my heart and soul through my whole time here. And so when Ken asked me to talk about moral injury and the impact on emergency healthcare providers, I thought it would be a time to really put pieces together. And fortunately, Dr. Rini brought up the other thing, and that is underlying causes. That we know that a large percentage of the issues coming into the emergency areas across Indian country all have underlying causes. And so we're going to talk about that and try to take a look at what we do. Now, the first thing I'll quickly mention is that I direct the One Sky Center. We've been working comprehensively across Indian country, both in the United States and Canada, since 2003. And I always take the opportunity to meet with tribal councils and leadership and try to partner that with the medical care. If I have an eternal hope and optimism, is that mental health people will work with the rest of medicine and the rest of the community, that we need to get out of our offices and into the sites where we're needed. Sometimes that's outside the hospital. Sometimes we need to be at the tribal council meetings. Well, today we have goals to talk about. There are 5. I want to talk about what's the pre-pandemic conditions? Where were you when the lightning struck? I always, when I try to look at a problem within American Indian health, I try to take a look at where were we originally, where are we now, and what are the exact problems? How do they fit in the context of the current situation? Then we'll explore how the pandemic highlighted and changed perspectives on physician, mental health, and wellness. And probably the important point that Ken asked me to talk about is to introduce the concept of moral injury. How does it play with burnout, PTSD, stress, anxiety, and all of those other pieces that kind of go hand in hand? Also, we'll describe organizational and personal strategies to overcome moral injury or all of those other problems that we mentioned. And then finally, to discuss current trends in physician mental health and wellness. So those are our goals, and let's hang on to our hat and go forward. I always think it's important to kind of have a good stomp dance at the beginning to find out where were we, where were the tribes, and where were you when this thing started. One way to look at that is to, I'm going to, well, I guess I'll just leave it the way it is. The slide is interfering with my view of the title, but where were we when the pandemic happened? What was the health, morbidity, and mortality? And we all know there were problems in Indian country. Pre-pandemic, we have alcohol and tuberculosis at 6 times the general population, diabetes, accidents, poverty, depression, and probably suicide too, at about 3 times the general population. And violence, we really don't know, but we know that it's high. So what's happening now? During the pandemic, we've had increased depression and anxiety. The mental illness severity in Indian country has gone up a bit. I think that's because we've lost contact with patients and they are not taking their medications. There's alcohol and drug problems increasing, suicide, anger. So with all of that going on, I can only guess that your emergency rooms have been increased in issues and problems, not just with COVID. I always try to ask, why is that going on? And I eternally talk about the social and economic factors that drive health outcomes. We all know about social determinants of health by now in the public health system. And we know that the economic stability, the neighborhood, the housing, education issues, food security and safety, along with availability, community and social context is very, very difficult to deal with. All of these factors play into what the healthcare system has to deal with. We know that we have increased morbidity and mortality. We've got lower life expectancy. Healthcare expenditures are a little bit on the high side because of geography and access. And so we know those problems are there and they relate to the social determinants of health. This is a diagram that I put together recently when I was talking with tribal council about how poor chronic health and increased risk for mental illness is affected by unemployment, poor access, poverty, poor housing, low or poor education. All of these factors kind of tie into what you're doing in the emergency room. And these are the very people that are coming in with COVID problems. And so we really have to take a look at untangling this. And I know that it gets very confusing, when you're trying to find help and resources available, and how do you move people through the emergency room. So this is how things were in Indian country. Health services are under-resourced, severely limited access to health care, insufficient monies for chronic illness care. And chronic illness, I think Dr. Rainey pointed that out, that there's the acute care illnesses that are manageable and workable, and you know how to go through the process. It's the chronic illnesses that keep coming back and they're hard to untangle and hard to deal with, that become an issue in the emergency room. There's poor housing, persistent poverty, staff vacancies in the healthcare system. I don't know how that is in the emergency services area, but I bet that there's got to be problems there. It's occurring against a backdrop of increased prevalence of mental health issues. Now, by the way, I'm going to talk mental health issues, not mental illness issues. Most of the things we're talking about are not diagnostic categories. They're emotional problems and difficulties and struggle, sometimes with just logical debate about how you move forward in a decision. We do know that anxiety and depression, this is not an Indian slide, but we know that there's increases in the public across country over the last year, considerably increase over time. So the main things about it: loneliness or isolation, past trauma. Some of our people in the mental health services are also Native. They might have some issues about post-traumatic stress and historical trauma. And so those things can come up within staffing. There are relationship problems, current events, news and politics, coronavirus threat itself, grief and loss, financial problems. These are things that the Mental Health of America put together in July of 2020 as that's what we were facing as we were in the pandemic itself. And then the first annual meeting of the group that you're trying to find a new name for, the American Rural Emergency Medicine Group, had their first meeting in 2019, and the topics they had were typical topics that you would expect for a first-time meeting. Imminent delivery in your ED, flow metrics, ultrasound, acutely agitated patients, mass casualty, chest pain, transforming emergency care, staffing, sepsis, cerebral vascular emergencies, and breaking of bones. Those are the things that you had. And then along came the problem of COVID, and it didn't allow the scheduled meeting in 2020. I understand you had a meeting, but I've been unable to find the topics that were in the second meeting that you had. But now as we kind of move forward, we've looked at the here and now before the pandemic and how it was during, but now we want to explore how the pandemic highlighted or changed perspectives on physician mental health and wellness. Today's meeting and tomorrow's meeting: COVID, 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 moral injury, difficulties that are happening within the group. A very good way to be talking about what's been a tidal wave of problems across Indian country that kind of get your attention in a different way. And I think that's what Ken was talking about as he's driving to work, that you're just thinking about the next thing that needs to happen. Now, according to the national survey as conducted by Mental Health America from June to September in 2020, 93% of healthcare workers reported experiencing stress, 86% reported anxiety, and 76% reported exhaustion and burnout. We didn't know how at first to take care of these patients, and so the clinicians were feeling desperate to consider the very best care and we were learning how to do that over that time period. Other comments about what seems to be happening: it's a huge roller coaster ride. Stress, anxiety, PTSD, burnout, and moral injury have all been used to describe the emotional conditions experienced by emergency and frontline staff. Now, those are the issues we're going to be talking about in this talk. Of those terms, only PTSD has been established as a diagnostic category, and it could contribute to a reemergence of historical trauma in a few patients and maybe in staff. Experiencing chronic stress and anxiety can lead to more severe depression and anxiety requiring treatment. I remember Dr. Rooney's comment about underlying causes. And, even with COVID, we need to kind of think about what are the other things going on with that person as they come into the emergency room. The issue about COVID and a good mental status exam, what would we see amongst our peers and colleagues? Moral distress, anxiety and suicide ideation, possible increases in burnout, depression, anxiety, and insomnia, excessive work hours, inadequate PPE, infection among medical staff, feeling a lack of support, and extensive media coverage, which is a little bit scary at times, fatigue, discomfort, difficulties in communication. And remember all of this on top of a rather chaotic presidential election time period. So we really had quite a year as we move forward. And I wanted to kind of start some discussion about the burnout syndrome itself. It needs to be discussed. Majlik talked about burnout as being emotional depletion, detachment, and cynicism, and low personal achievement. So those three criteria. Now remember, burnout syndrome is not a diagnosis. It's not something that you can immediately think about and say, oh, well, let's provide some medication and work with this. These are things that you need to work through intellectually as you kind of look at your life and look at what's happening around you. There was a review by the AMA and Medscape of 14,000 subspecialists in an interesting review from 2013 to 2017, looking at burnout. And emergency medicine was at the top of that list. At the end of 2017, they had a rating of 59% expressing burnout compared to the other subspecialties. But then I looked at this year's review of burnout and suicide in 2021, and it's interesting that emergency medicine dropped down to number 11 at 44%, so 59% to 49% during COVID. I thought that was interesting and something that we can talk about a little bit, whenever you see that type of a change in how things are. One physician described it this way. He said, if a physician did not have a team before the pandemic, they certainly have one now if they're still practicing. Perhaps it just needed to be realized through this crisis. Balance of life, supportive professional teams, and practice of self-awareness are keys to preventing burnout. I wanted to kind of put up a slide that is, at least it's personal to me. We have the balanced life and a life that's imbalanced. I think that we as physicians struggle with that chart on the right-hand side of your screen. We have bought into this work. We believe in it, and it feeds our emotions. It feeds how we feel about ourselves. And if I can recommend anything, is to try to take time and move over to the balanced life approach. It will help you greatly. As an emeritus member of Oregon Health Sciences University, I'm now retired, and I kind of have a different way of looking, but I'm still working. I don't work full time. I work about 60% of the time. And so I'm moving more into that balanced life approach and taking care of family and other issues in my life. By the way, my topic is banjo. I'm still not very good at three-finger picking, but I'm still working on it. Well, let's move over and talk about post-traumatic stress disorder, because that's something that you see in the emergency room, and maybe you see within some of your colleagues in the emergency room. You all know that trauma is kind of the way of looking at post-traumatic stress. There's a traumatic event in one's life and they re-experience it. There's avoidance, unable to function. It lasts for about a month, and it has arousal as it kind of resurfaces and goes forward. Well, 70% of the population of the United States have seen trauma sometime in their life, but only 7% of the national average experience PTSD. Within emergency medical physicians, that number is 14%, and it's probably risen a bit with COVID. I've read in some maybe less reliable comments that it's up at 21% now. Women are more often than men in having PTSD. Well, now let's talk about the real issue about moral injury. How are we going to talk about that and deal with that? And I wanted to give you right offhand the healthcare view of moral injury. The concept of moral injury has been around a long time, and it's usually related to war. It was especially talked about in Vietnam era, where there were killings and things that happened in communities that people felt very badly about when they had occurred, and so they were struggling with what's right to do, and if you're given orders to do something that you don't feel right to do, and so that's been discussed since the Greek and Persian wars. So we have a long history of talking about moral injury, but Dean and Talbot, who kind of been leading the discussion about, moral injury really relates to healthcare people. We have a great deal of struggle. And they comment that moral injury describes the challenge of simultaneously knowing what care patients need, but being unable to provide it due to constraints that are beyond their control. It happens frequently to people who choose professions that expose themselves to suffering or evil in the world. That can be police, it can be the military, it can be lawyers, it can be nurses, it can be physicians. So, if you shatter one's view of the world, their moral conditioning and belief in what's needed, that means that your belief and trust in others and sometimes in yourself is reduced. It happens because they're frustrated with the fact that they can't provide the care for which they were trained to do and took oaths to provide. And so that's what Ken Bernard is talking about when he begins to question the issue of our struggles in the emergency room when we can't get what we need done and believe in done. And that kind of conflict maybe is a better description really than burnout, which sometimes is what the organizers of systems will say, it's your problem, your burnout, you're not dealing with this difficulty. Well, moral injury is a different way of kind of looking at the system. One last comment about PTSD and moral injury is that PTSD is a fear victim reaction to extreme conditions, and it damages the amygdala and the hippocampus. Moral injury is a reaction of conscience. It requires a healthy prefrontal cortex where empathy and moral thinking occur. So I'm trying to make the distinction that we're not talking about a mental illness here. We're talking about struggles with our own judgment and how we see things happen in front of us. And when things happen in such a way that triage becomes an interference for what we really want to see happen. So some examples about moral trauma having to decide who gets a ventilator, and who gets saved, giving up on people that you'd normally not give up on, loss of colleagues that you're treating. I don't know if that's happened to this group, but I'm sure that it has. Uh, the end of life scenarios, dying alone. We've seen that on television and how painful that is for families. But how about the nurse or the doctor who's holding the phone so they can have goodbyes? There's a rationing and a rationalizing about patient access to good quality care or a bed. Desire to improve patient experiences, improve quality of treatment. All of those things come into conflict. You're trying to improve, and all you can do is float along at the surface. Shortage of essential equipment, supplies, and fear of contaminating loved ones. That must have been on the minds of many of you. It was on my mind as well when I have to do work with patients in a more direct way instead of a televideo. So rationaling and poorly designed media records, increased paperwork, administrative demands. I put those in yellow because I really don't think they belong in discussing moral trauma, but they were listed, and I wanted to at least let you see how broadly it's defined. I wanted to put in another slide about moral distress and moral injury. The argument is that if you can get at the issue earlier, you can do an intervention. You can talk with the person. You can have groups talk about the right and the wrong of situations. And so when this moral distress emerges, maybe you can prevent it from becoming more serious with a deeper emotional wound, as you see on the red hand side of the chart. Well, let's describe now organizational and personal strategies to overcome moral injury. When I talk about things like this, I always try to include my slide of a Northwest tribe canoe journey. And the canoe journey is always important because everybody in that boat needs to be in sync. They need to have their oars in the right place. They need to have the depth of the water in the right place with the oar. They all need to be consistently in timing to be able to get the work done. And that is your emergency room. That's what you're trying to do, is to have people in sync and have the strategies to overcome this moral injury, which, moral injury can emerge long after events are experienced. They can also occur right after an emergent or catastrophic situation. So there could be the blow up at one time where you say, boy, where did that come from? The other is, where it came from. It's right there in front of you, and you have to deal with it at the time. Then it does create isolation and withdrawal of the individual, and it can affect many professions that we've already talked about. So it also can evolve as trauma in healthcare workers, and that's something we want to really pay attention to, because once again, with PTSD, we know that trauma can cause epigenetic changes, and we want to be very aware of that issue. Usually, when I take a look at how to understand emergency staff situations, I try to do a broader base where you have the individual, the organization, and society at large. And for the individual, we want to look at resilience and stress reduction. For the organization, we want to make sure that the healthcare workers' needs are met. And in the broad society view, we want to make sure that funding and policies are in place to help mental health programs in the emergency room. I don't know about you, but I go around all over the country consulting with tribes, and I realize the tremendous burden that chronic illness care has on emergency rooms. And one of the issues is, how can we refer these patients? How can we find placement? Where's mental health? that's something that we'll talk to in just a little bit. One example, I wanted to give you several examples of ways to deal with this. And the AMA has a very interesting creating a resilient organization caring for healthcare workers during crisis. Now, they argue that there's 3 points. There's the before an event. You need to have something in place to deal with a potential problem. So creating a resilient organization that understands what happens when an event happens is important to know. Then you want to know the during, supporting physicians and other healthcare workers during a crisis, and then the after. How do you learn from the position and deal with the crisis in a better way next time it occurs? And I'm going to kind of jump into that and say the before. There's some very specific, the AMA has some very specific recommendations that when you talk about the American Recovery Rescue Plan and money and resources, you might want to create a system to deal with these types of problems. You can create a wellness officer to establish professional well-being program, create a caring for the healthcare workforce during the crisis plan, and develop a plan to support workforce needs and establish a plan to suspend or reduce non-essential tasks. All of these things could be in place before a COVID problem. Hey, wait a minute, where did I hear that? Didn't Obama have a plan? Didn't he have a committee? Didn't he have a way of dealing with the potential of a pandemic? And it didn't appear. And the country paid a price for that. And I think that emergency rooms should take advantage of that and develop a plan on how they're going to handle these kinds of situations. The next issue is during. And we need to make sure that we're supporting physicians and other healthcare workers during crisis. Their environment needs to be protected. They need to have a place to rest that's safe. They need to be able to look at the current situation. And if there's changes, we need to adapt a new plan. So you continually address what you have in place to move forward. You can connect with other institutions and share, learn, and work together. You can assess the needs and stress level within the workforce on a regular basis, and I'll show you a little bit about how to do that in just a moment. You can also adapt a support plan to meet the evolving needs. And then there's the after. You need to take a look at learning from the crisis and how do you do that. A debriefing process, unit by unit, would be very, very useful to have, making sure that the teams are working together across systems. And I would bring mental health into that. If mental health isn't a part of your emergency room, I would invite, if you have a psychiatrist or psychologist in your system, to invite them to be a participant, to go through these things, and maybe even participate in monthly meetings to see how things are going in the ER. Wouldn't it be nice that you could prepare for these pandemics, but you could also try to address the problems with dealing with alcoholism and drug abuse and placement of patients afterwards, and the chronic care issues that emergency rooms are not really equipped to kind of manage in a good, easy way. So I think there are ways that you can take a look at planning. I also, below each slide, you can go directly to the website and take a look at how to do these things if you decide you want to develop an actual work plan. Now, there are other plans I want to share with you. The Canadian Medical Association has another way of looking, and they have a system of what is my color right now. And they use this for self-assessment. Are you doing well at your baseline? Are you kind of in that yellow, a little bit, worried and maybe short fuse? Those are the things you see. You can rate yourself and where you are in the process. Ken could have used one of these before he got into his car to go to work, and maybe after he got into his car when he's leaving work, he could see how things are functioning in comparison. The nurses have a similar model. You might imagine nurses do a little bit better job than physicians in taking a look at things that are pressing in their job. When they talk about moral resilience, they look at mindfulness and relaxation therapy as approaches, and they show their staff how to do that. They have self-stewardship, nurturing one's well-being as another way of dealing with this. And of course, they have lots of support and continuing education. And the last thing I'll mention is the cognitive processing therapy. That's a program to help victims of trauma. And so once again, they're going to engage before it transcends into something that's more difficult. A last example I'll give you, this is from the National Fallen Firefighters Foundation. It's a list a little bit like the Canadian group. They have, and you can rate yourself, or you can use this as a leader of a program to rate your staff. This, by the way, it was developed right after 9/11, but it was used very effectively last year in the fires in the Western United States. So it's something they actively use and endorse in working with their staff to make sure that they're in a safe position. The firefighters are just like the emergency room. They're very vulnerable to change rapidly, and so good self-assessment is an important process. Well, finally, I'll discuss the current trends in physician mental health and wellness. These are always important for us to understand and to deal with over time. And I wanted to start a little bit by, the COVID pandemic. It's presented unprecedented challenges due to prolonged uncertainty and heightened anxiety, immediate threat, and personal and family safety, social isolation, witnessing physical suffering and death, and evolving professional demands. These individual stressors combine to induce hyperarousal, hypervigilance, sleep disturbance, intrusive thoughts, depression, and grief. You notice nowhere in there did I give a psychiatric diagnosis. These are reactions to stress. These are difficulties that people are having. And I think it's important for us to not be defensive about this. And, the last thing we need to be doing is talking about the stigma of having a mental illness problem. You all know that's an issue. Even when you get your medical license in a state, you have to talk about it. And if you say yes to certain things, a little bitty star shows up in how you're doing. So, physician mental health, emergency medicine can be turbulent and overwhelming. Nurses and other healthcare providers facing life and death consequences each day. The point too is we need to dismantle the current barriers for physicians who seek mental health treatment and reduce the stigma of physicians' mental illness. Now, I'm going to give you a kind of a longer group of things to talk about here from the Annals of Internal Medicine. This is another series of recommendations on how to deal with mental health issues. And there are 7 points that they give you. I'm going to focus on the last 3 because they're most consistent with my talk, but I wanted to give you all 7. There's a need for resilience and stress reduction training, providing for clinicians' basic needs, food, drink, adequate rest, quarantine appropriate housing, transportation, childcare, PPE. All of those things need to be available readily as opposed to the way they were this last time. Stress the importance of specialized training for pandemic-induced changes in job roles. Recognition and clear communication from leadership. I haven't talked a lot about that, but the leadership issues are critical. Our leaders have to learn how to think through and open up about healthcare issues. There's an acknowledgement and strategies for addressing moral injury that I'll cover more in a minute, a need for peer and social support, and normalization and provision of mental health support programs. So those issues I wanted to cover a little bit more detail. You know, ethical, social, and professional obligations towards the profession are frequently reported as the core motivator for physicians and clinicians' decision to provide care and putting themselves at risk. This commitment in serving others, even at the cost of their own well-being, makes clinicians a uniquely vulnerable population. Moral injury is defined as psychological distress caused by a betrayal of what is right by someone in authority in a high-stakes situation, or witnessing, perpetrating, or failing to prevent acts that transgress core moral beliefs. So clinicians should be encouraged to seek informal support from colleagues, managers, chaplains. We'll talk a little bit about how to do that in just a minute, but also to have rapid access to professional help it should be provided. As a result, leadership must proactively and routinely monitor the psychological well-being of their teams. You can go back and look at the Canadian model and the firefighters model and the nurses model and the medical model to look at how leaders can do that work. So social support interventions are important. You know, the COVID-19 pandemic interferes with the ability to connect with colleagues, even one's own family. So owing to mandatory infection and control issues, those are the big problems. Social support social support decreases stress and anxiety, and it increases self-efficiency and sleep quality. So having the feeling of social support with families and with colleagues is critical, that we don't lose that during the COVID intensity. To sustain clinician well-being, heightened attention must be paid to fulfilling their social support needs. And the final issue is routinely holding rounds or special debriefings, interpersonal forums for healthcare professionals. That way they can discuss the emotional, social, and ethical challenges of work. You need a little time out to do that. And I think that that's why it might be useful to have once a month, have someone who's skilled in this business of dealing with moral injury to come and be at your staff meeting to talk about what's going on. We're not looking for psychiatric diagnoses. We're looking at making it okay to talk about the issues and to find a way to deal with that. So, you know, the provision of mental health support isn't really a standard practice in the United States. We are unlikely as physicians to seek out psychological support, and there's a whole variety of reasons for that. But, you know, leadership can kind of normalize mental health support by modeling self-care and talking about the problems and the anxieties that they have. And staff development can has a culture of caring and frequent check-ins. When I worked with the tribal councils, I made the same proposal to them. Whenever they had their tribal council meetings, you know, people are struggling in the group, and the leaders need to talk about, hey, I was really uncomfortable last night. I had problems because one of my family members has got COVID, and I'm worried about my children. You need to level with and talk about your own feelings, which makes it okay for other people to talk about the feelings. And that makes the check-ins more realistic. I mentioned that I would give you recommendations on other things. All of the pieces I gave you, by the way, I've listed, and I highly recommend the AMA, the internal medicine group, and this group here, your own group, has a program on physician wellness. And I'd highly recommend that you, if you haven't done it, to get online and see what's there. If not for yourself, maybe for some of your colleagues whenever you talk about it. There are other well-being resources. I mentioned 3 here. I like TED Talks myself, but there are 10 talks about burnout, and they have experts in the area that are giving these great and wonderful talks. I like to put those things on, and I kind of, since I'm there by myself, I catcall and make smart aleck comments, and I can act out as they're kind of giving their brilliant moment of enlightenment about burnout. But I find that healthy for me. I like doing that, and it doesn't hurt anybody. There's a program called Provider Resilience. It gives healthcare providers tools to guard about burnout and compassion fatigue, something that I think would be useful for you to look at. And Stanford Medicine has WellMD, which is another center, and it sounds like Dr. Rennie has material at Brown University that would be useful to look at. So in that context, I want to thank you all, and I mentioned I'm also a resource. I've been doing this a long time. I've worked with over 200 tribes in my time working in this area, and that's my cell phone number, and that's my email number. You're welcome you can call or text. You can also send me emails, and I'll try to respond to those as quickly as possible. So I want to thank you all very much. It's a pleasure always to be with people who are working in Indian country, and I'm humbled by your work. I'm pleased to be here. I am so impressed with the previous speakers. You have challenged me. I've got numerous notes to move forward with ideas that I have. So thank you all very much.
Thank you, Dr. Walker. This is Sean DeAndrea. I'm the co-moderator for today's session. Dr. Bernard is transitioning, I think, over to phone to call in. There's a lot here for us to think about and take back to our practices. And I've got a couple questions. I also asked for our attendees to share any anecdotes or stories of practices to help improve resilience or address burnout in their own departments or hospitals. So we'll see if anything comes up there, but wonderful presentation. I'm curious, you mentioned that, and it's not only true, of course, for physicians, but for all health professionals, that coming forth with a concern about one's own mental well-being is considered a fraught process, even today when we have had more discussion around concepts such as burnout. So I'm curious what you might share with the group about strategies or a very concrete way, if you're working in a hospital or a department that does not have an infrastructure around provider wellness, nurse wellness, and many don't. And unfortunately, I think many in the space that we work do not. What would be a wise and effective strategy for an individual clinician or department level leader to approach administration about this? Are there, and I've asked this of some other speakers, I'm very interested in standards that are emerging in the wake of COVID. Can we point to other practices and say, hey, this is something we need at our hospital, this is an emerging standard, why aren't we doing this? How would you counsel folks on pursuing the implementation of a program around resilience and burnout?
Well, you hit the point, and that is that there's great variability across the Indian country with what's available. Some people will have staff immediately available who know something about how to work with physicians. I want to make a little bit of a point. Across Indian country, the mental health care teams are focusing on those chronic illness problems, and they're trying to deal with those. And when they come and say, want to do some work with, say, the emergency room staff, that's a different technology. And you want to make sure that the staff understands that. The first thing I would do if I didn't see it immediately available is I'd go to the regional IHS office and I would ask for their advice. I would make it clear that it's something that would be useful. And so I'd take it through the system. That's the first thing I would do. The second piece of advice would be, what are other people in your region doing with the same problem. So you kind of get a leveling of what's going on in the rest of the emergency services. The third thing would be, is there somebody in your neighborhood, a psychiatrist or psychologist, who could be helpful, who isn't connected with the Indian Health Service, who might be available for, say, 1 hour, 2 hours, I'd say 2 hours a month. Just invite them to come to your a monthly meeting to talk about what's going on and how things are happening. I would tell you that when I do those kinds of things, and I have done them in the past, the last thing people want to see is a psychiatrist stepping into their office. And so there, there's a stigma, and I've learned to keep my mouth shut and listen and try to go with the flow of what's there. And you need a good mental health worker who knows how to do that. I think that a mental health worker needs to know the flow of the talk and where the pressures are before they jump into things too quickly. So that's the person I'd be looking for. Locally, if I could find somebody like that, I'd have a nice long talk about it and see if they've done work like that. I'm trying to make the point that you don't want a mental health person working with psychopathology in your unit. That's not what they're looking for. They're looking for social support. They're looking for encouragement and kind of intellectual decision making and development. That's something that many psychotherapists are incredibly skilled at. And so the work is out there. I give you one last recommendation. Call your state psychiatric district branch. Every state's got a psychiatry program, and you can call them and you can ask for, is there somebody available who can provide that kind of care? I believe that the tribal council, if you're a 638 program, would be very willing to provide 2 hours of support monthly to do these things. And by the way, I don't want to diminish the thing that mental health workers do need some psychiatric support at times with actual diagnostic problems. And so that's the other thing. We want to be sensitive to the fact that there are people that will need help, they will need medication, they will, but since there's no interrelationship, it becomes hard to make that happen. And that way we isolate the emergency people, become isolated in what they do, and they feel like they're the only people in town. And that's the problem. You don't need to do it alone. Somebody said that earlier, it's a team thing. And most good mental health people will sit down and work with you the best they know how to try to relieve the stress and strain of the situation.
Thank you. And that would not have been intuitive to me to go to really advocate at higher levels in the health system, even if it's outside the facility. Looking at some of the participants who I know and have had the honor of working with, it strikes me that for some of the facilities we work in, what needs to happen at the clinical level, it comes from the ground up, and we feed our leaders, best practice guidance for our departments. That's what we're hired to do. This is a situation where we really do need some of the help, I think, from a higher level, because the clinical leaders, the clinicians themselves have been in the trenches. So thank you for sharing what I would describe as again, not an intuitive strategy to really seek at a high level support. Because it seems like, based on your talk, we're in the middle of a transition and a changing standard, an evolving standard. Yeah. Around wellness for clinical personnel. And I'm sorry, I need to correct myself. I should have been using the language moral injury earlier, not burnout, as I was.
Well, that's the interesting thing. Those terms aren't bad terms, but they're not diagnoses. And so it's kind of important that we think of it that way. Burnout's not a bad word, and moral injury is not a bad word, but we just want to. It's an intellectual process of trying to solve a problem.
I really appreciate the nuance of the difference of the terms that you educated us about. You know, one really puts a little bit of burden on the person experiencing the process. The other, I think, externalizes it a little more appropriately. I really appreciated that nuance. There's a couple of resources and examples of anecdotes that got shared in the chat. Dr. Dobia has talked about a practice in the Brigham Emergency Department of doing group breathing exercises before starting each shift. Which is a very grassroots effort to work on real-time wellness. And then Kate Elkins from NHTSA shared some resources that folks should have a look at in the chat. Cut and paste this link if they have time around guidance and resources for health personnel, safety, and well-being. Dr. Walker, thank you for really helping open our eyes to this and understand these challenges in a new way. I think there's going to be a lot of work in the years to come, even if we hadn't had COVID, to evolve our practice and the environment that we work in. COVID's probably, I would say, accelerated the need for that. And with folks like you out there providing this education, we have a better chance of getting it right. So thank you very much for taking the time to talk about this today.
One of the things I'll quickly tell you is that anybody's welcome to call. One of the things I feel good about is that I can help make connections happen. And, that's probably the most important thing is to, there's a problem there. Let's find a way to resolve it. And I'll do my best to be helpful. So don't hesitate to give a call.
Well, thank you again for normalizing an experience that, based on your statistics, affect a plurality of healthcare personnel. So thank you again.